the annual conference. And we are going to the first session of today, which is on clinical pathological conference from bench to bedside, third part. The lead faculty is Dr. V. Viswanathan, and please put it up. The chairperson is going to be Dr. Gaitri Narayanappa from NIMHANS. Dr. Gaitri is a professor in the Department of Neuropathology, NIMHANS. Her main interests are neuromuscular disorders and neurometabolic disorders. She has passion for electron microscopy. She has 60 publications in peer-reviewed journal, international and national. Awards, best research papers, 6 national and international, member of several national and international bodies. And now I request Dr. Viswanathan to put up his biodata. Biodata, sir. Yeah, thank you. Yeah, Dr. Viswanathan is a consultant pediatric neurologist, graduation from Chennai in 1985, qualified as a pediatric neurologist in the UK in 1996, member of British Pediatric Neurology Association, Indian Academy of Neurology, Neurological Society of India, and Indian Academy of Pediatrics. PhD in Pediatric Neurology, Dr. MGR Medical University, Chennai, Tamil Nadu, consultant pediatric neurologist at Kanchikamakoti Child Trust and Apollo Hospitals, Chennai. I hand over the mic to them. I request Viswanathan and Gaitri to conduct the session. Thank you.
Good morning to you all. One of the good things about starting early is most people are awake, and I hope to keep you all awake for the next 1.5 hours. What we are planning to do is let Professor Gaitri, who really has been helping us a lot to set up all the muscle staining and the muscle-related work at Chennai. And therefore, I thought it's apt that she starts off the session by giving us an idea of what are the important markers, basically also about how to send a muscle sample, because many times if you don't send the right sample, you get the wrong, you don't get the right report on it. And therefore, I thought it would be good if she could address all these issues and give us a clue as to what is the right way to send a muscle biopsy, where do we take a biopsy, or rather, how to preserve the muscle specimen, etc. Over to Dr. Gaitri.
Good morning to you all. I'll start off with the like Dr. Vishwanath told you all, how the muscle biopsy has to be sent. Now that is very important aspect for the diagnosis of muscle disorders. So I'll start off without any delay. Now, I guess some of you are all pediatricians here, or the residents who are doing pediatrics. Now, infantile and the childhood neuromuscular disorders can be classified into disorders occurring at birth or early infancy and disorders occurring in the childhood. Now, I have highlighted some of them. Now, those are the things which I will be concentrating on. The the disorders can be again classified into those of them with infantile hypertonia with significant motor weakness, which are all these conditions, the infantile spinal muscular atrophy and a whole lot of them, but the ones I have highlighted in green are the ones which have significant motor weakness and where a muscle biopsy is indicated. So I will be concentrating on all these conditions. Now, the other list of conditions where there is no significant motor weakness, and I think all of you know about these ones. Now, how do we go about? Now, first of all, one need to evaluate clinically, then you have to do basic biochemical investigations, you have to go in for electrophysiological studies, imaging, and of course you have genetics for a couple of conditions now. You can send the blood samples for genetic analysis, failing which then muscle biopsy becomes a very important tool for diagnosing these neuromuscular disorders. Now, there are several questions one need to ask before you do the biopsy, and I have just listed out these. Should you do the biopsy at all? And if you do the biopsy, which of the muscle is to be biopsied? Then how big a piece that you have to send? Then how to send the biopsy? Now, this is absolutely essential. And how to interpret the biopsy. Now, once the biopsy comes to the pathology lab, how we interpret the biopsy, then how to understand this report. Now, there are several conditions, and how do you come to a diagnosis of these conditions? And what does it mean to the patient? Are we offering anything extra while doing or conducting all these investigations? Now, there are certain guidelines I would like to put up and then see that people follow this. Step one is to select the patient. Then after having selected the patient, you have to select the muscle for biopsy. Now, there are several muscles in the body, and which of the muscle are you going to biopsy? Now, that is very important. And there are several techniques of performing the biopsy. And one of them is the needle, the other one is the open biopsy. I'll tell you the advantages and disadvantages of these. And then what are the procedures that we follow in our laboratory? I'll be confining myself to what tests we do in our laboratory. Now, number one is how to select the biopsy. And there should be clinical evidence of a muscle disease. There should be weakness. One of the markers for doing the muscle biopsy is the elevated serum creatine kinase levels, which will point towards a myopathic feature, and EMG, of course, the electrophysiological studies pointing towards EMG. Now, this is for adult population. Presence of systemic disorders that may involve muscle are some of them, the vasculitis and the sarcoidosis, where you do need a biopsy for diagnosis. Now, I told you there are several muscles and not all of them are biopsied. There are certain groups of muscles that you need to keep in mind that you have to biopsy. Now, you have to see the grade of the muscle. The grade of the muscle is anywhere from 0 to 5, 0 being the significantly involved muscle, while 5 being the normal muscle. You need to select the grade between 3 and 4, which is supposed to be the moderately affected muscle in chronic cases, whereas in acute cases, you have to select a severely affected muscle. Now, this is absolutely essential. A moderately affected muscle, and in case of all the chronic diseases, whereas in acute conditions, you have to have a severely affected muscle. Then, the proximal group of muscles, most of these conditions have proximal muscle involvement, and the group of muscles that you would prefer to biopsy is the quadriceps, and very rarely we biopsy the biceps. And if it is a distal muscle involvement, you have to choose a distal muscle, and the preferred biopsy of a distal muscle is the tibialis anterior. Now, I told you there are advantages and disadvantages of performing the needle versus the open biopsy technique. We, in our institute, we follow the open biopsy technique because it gives us the adequate tissue that we require for conducting all the investigation that is needed to offer the diagnosis in these conditions. Now, when not to do biopsy, there are certain conditions where the muscle is involved, but then you should not do the biopsy. Now, these are, remember, when it is an anterior horn cell, you cannot distinguish an anterior horn cell disease from those with the peripheral nerve involved, where the muscle show identical features like the spinal muscular atrophies or anterior horn cell disorders. Then the conditions where you can diagnose by electrodiagnostic methods, you need not have to biopsy, like for example, the myasthenia gravis and the myotonic disorders, there's no need to do the biopsy because it's a clinical and electrophysiological diagnosis. And biopsy is not indicated in some of these conditions. Now, XP21 disorders or the dystrophinopathies, which is the most common muscular dystrophy, there is no need to do but biopsy. And biopsy is indicated only when the genetic test fails to detect the mutations. Spinal muscular atrophy, this is one very important feature I would like to tell you, that if you biopsy the patient before 6 months of age, now the onset of disease in these conditions is anyway in utero to 6 months of life or to 18 months of life. And if you do a biopsy within the 6 months of life, you will not get any diagnosis on the muscle. And of course, you have the genetic tests available now in India, so you first do the genetic analysis, failing which then you do a biopsy, but do the biopsy after 8 months of life. Then, of course, there are other conditions where genetic tests are available, the myotonic disorders, the facioscapulohumeral muscular dystrophy, which can also affect the children. Then it is not indicated in any of the endocrine disorders or the channelopathies. Now, this quote I always quote in all my lectures because it's a very important quote, which is by Dubowitz, who is the father for the muscle pathology. A small fragment of an unnamed muscle coiled into a disoriented ball after being dropped into formalin, which is a fixative that is used, is unlikely to give any meaningful interpretation, no matter how careful you process the tissue. Now this, everybody, all the residents, I tell you that you have to remember that if you fix the tissue, there is very little thing that the pathologist can offer. The most important is how you send a fresh muscle biopsy. Now, this is all for the residents. Now, after you do the biopsy, now how do you send the biopsy? Now, this is very, very important. You take a gauze piece and then you put a few drops of saline on the gauze piece and then drop in your muscle. Now, see the amount of muscle. This is enough for offering the diagnosis, and this you can also preserve the muscle for subsequent analysis. So this amount of muscle is sufficient not to do an excision biopsy like the ones which are sent here. Some of them do stretch it and then tie it on either ends. Some of them tie it onto matchsticks, scalpel blades. Please do not do that. You have to send the muscle fresh, and the amount of muscle that is seen here is sufficient. A 2 into 2 centimeter bit is sufficient for all the diagnostic procedures. Now, you should not put it into a bottle containing saline. Now, this will create a lot of artifacts, and which causes, we cannot interpret the tissue because of the artifactual changes. Now, after having done the biopsy also have to be put, this gauze piece with the muscle should be dropped into a Ziploc cover, and this Ziploc cover should be put into another Ziploc cover and dropped into a flask containing ice. This is an ordinary ice, no dry ice, it's just the ordinary ice that you have to send. And how fast you send the biopsy is again very important. It has to reach the pathology department within 4 hours for all enzyme histochemical stains, and not for immunohistochemical immunohistochemical stains. Now, immunohistochemical stains, if one needs to do, then you have to send the biopsy within 20 minutes and not later than that. Now, after having received the muscle biopsy in the lab, these are the things that we do. We do routine histological stains on both fresh and the fixed tissue, and the most common one is the hematoxylin eosin. I'll tell you why we require all these stains. Then we have another stain called the Mason's trichrome, which will tell you about the increase in collagenous tissue. Then we do the enzyme stains, for which you absolutely require fresh tissue, immunohistochemistry, fresh tissue, biochemical assays, again you need to have fresh tissue. For genetics, again you need to have fresh tissue, and of course for electron microscopy, which is an urgent test, you need to fix the tissue in 2.5% buffered glutaraldehyde. Now, this is how we do the fixing and subsequent cutting of the sections. You orient the tissue onto this aluminum foil. You take isopentene in a small beaker which is dipped into liquid nitrogen, and after this has attained the temperature of liquid nitrogen, we plunge the tissue into this, and periodically you need to check the consistency of isopentene. And once the isopentene is half solid, half liquid, and that's the consistency when you dip the muscle into the solution and then immediately transfer it into a cryostat, which is maintained at minus 20 degrees, and you cut these cryosections. Now, after having cut the cryosections, and what are we going to do with these sections? Now, I'll brief you about the various techniques. The number one, what we do is these enzyme histochemical stains. Now, these are the paraffin sections stained for hematoxylin eosin and Mason's trichrome, whereas all these are the enzyme stains. This is hematoxylin. This is one stain called modified Gomery's trichrome. The rest are the enzyme stains. Then we do this immunohistochemical stains to identify the protein deficiency or the protein surplus disorders. We also do immunoblots for again, for these protein surplus and protein minus disorders. We do enzyme assays for the metabolic disorders. And we also preserve a small fragment for further studies if required. Now, we'll go to the pathology of these muscle disorders. Here you have the hematoxylin eosin stain section, this is a paraffin section, and this is a cryo section. Now you can see for yourself the difference between the cryo section and the paraffin section, how well the contour of the muscle and the other morphology is preserved on the cryo section versus the paraffin sections. And the hematoxylin eosin will give you the general histology and the cellular details. The normal muscle is polygonal with peripherally placed nucleus, and this is how they are organized in a given fascicle. If you look at cases of neurogenic disorders, as in the spinal muscular atrophy, for example, this is what happens in them. This is the normal normal features, while what has happened in this particular one is you have a few fibers which are slightly large, and then you have the fascicles which comprise these small atrophic fibers. Now, based on this, we offer the diagnosis. Now, this is, I've said, myopathy. Now, myopathy is all those muscular dystrophies, the inflammatory disorders, the others come under the myopathies. And this is one example of a muscular dystrophy where the muscle fibers are no longer polygonal. They have become round. There is variation in the fiber size. And you have certain fibers like this, which are the necrotic fibers or the degenerating fibers. Now, based on this, we offer the diagnosis. Now, this is one stain which is called the Mason's trichrome, which is done on the paraffin sections, where the normal Mason's trichrome is like this. You have the perimysium, which is moderate, which is generally seen in a normal muscle. These are the individual muscle fibers, and the thin blue line that goes around individual muscle fiber is the endomysium. Now, what happens to endomysium is there is increase in the endomysial collagenous tissue in muscular dystrophies, particularly so in the Duchenne muscular dystrophy, and of course the other forms of muscular dystrophy which we will be discussing. And the limb-girdle muscular dystrophy, the amount of collagenous tissue is much less as compared to what you see in the Duchenne muscular dystrophy. Now, we'll go on to the enzyme histochemical stains and what is the importance of this particular stain. Now, it's the most important technique because it bridges the gap between the morphology and the biochemistry, and it is useful for assessing the internal structures, the fiber types. The muscle that we are talking about is the skeletal muscle, and the skeletal muscle consists of two different types of fibers, the fast and the slow fibers, and these can be identified by enzyme histochemistry by the difference in the intensities, and you will know which particular fiber type is involved, whether it's a fast fiber or the slow fiber. Then the metabolic state of the muscle, enzyme activity, and of course the proteins, all the muscular dystrophies. And please remember, if you fix the tissue either in formaldehyde or in glyceraldehyde or any fixative, it destroys the enzyme activity and you will not be able to carry out any enzymatic activities. Now, this is a list of enzyme stains that we use in our laboratory. There are several others, but these are the minimum that is required to offer the diagnosis, starting from nicotinamide adenine dinucleotide tetrasoleum reductase, that is NADHTR in short, succinic dehydrogenase cytochrome C oxidase, that is adenosine triphosphatase, acid phosphatase, phosphorylase, phosphofructokinase, and menadione-linked alpha-glycerophosphate dehydrogenase. These are the minimum that I have listed, but there are several others. And of course, the others, the modified Gomery's trichrome, and a very important stain which I'll be highlighting. Periodic paralysis, oil redo is for the storage disorders, and Congo red is for amyloid deposits. Now, this is how you see the muscle when it is stained with enzyme stains. I told you the two different types of fibers, the fast and the slow fibers, can be identified. This is the succinic dehydrogenase, this is NADHTR, and this is cytochrome C oxidase. So you have the dark stained ones and the light stained ones, which are organized in this particular fashion, which is the normal mosaic or the checkerboard pattern. Now, that's true for all these enzyme stains, and what is the importance of these, I'll let you know. The use of SDH and NADHTR, this is what you see. You see these structural changes within the muscle fiber, which is described as the lobulated fibers, which is one of the features that you see in the limb-girdle muscular dystrophies. The presence of these targets, which tells you about the denervation of the muscle, and one form of congenital myopathy, which is called the core disease, you can identify by this. And of course, the characteristic signature for metabolic disorders, particularly the mitochondrial disorders, is the presence of this ragged blue fibers. So these are the ones which you can pick up on these stains, which appears absolutely normal on the routine hematoxylin and eosin stain. Now, ATPase reaction again will tell you the different fiber types, and for all morphometric analysis, it is this stain that is very important. Here again, you have the type 1 and the type 2 fibers, the slow and the fast fibers, which are organized in a mosaic pattern. And the importance of this particular stain at pH 4.6 is you can subclassify the type 2 fibers into A fiber, B fiber, and C fiber. The C fiber, of course, is not visible here. So these are the type 1 fibers, or the slow fibers, and the fast fibers, which are 2A and 2B. So for subclassifying the type 2 fibers, you require at pH 4.6 ATPase reaction. Now, this is what you see on ATPase reaction. The groups of fibers, so this is actually from a case of spinal muscular atrophy type 1, where you have these larger fibers which are all grouped. This pattern is lost here in all these fascicles. You have just one particular type of fiber which is predominantly seen, and this we call it as grouping of the fibers. So there is grouping of all the larger fibers which are slightly hypertrophic for the age, and then you have these atrophic fibers which are also grouped. Now, this is the classical picture of spinal muscular atrophy when you do a biopsy after 8 months of life. Suppose you do a biopsy around or less than 8 months or even 6 months, then you don't get this picture. It appears absolutely normal. And this particular stain modified Gomery's trichome, the normal is what you see here, but these are the fibers which show abnormalities, and they are called as the ragged red fiber because they appear ragged and they are red, which again is a signature for the mitochondrial disorders. One condition called as Nemelin rod myopathy, which is a congenital myopathy, you can pick up using only this stain. And these are the ones which are the rod bodies. The NEMA means rod-like structures or thread-like structures. So these are the Nemelin rod myopathies. And the other important pathological feature you can pick up are these vacuoles, which are called as the rimmed vacuoles. They call the rimmed vacuoles because they're rimmed by this red granular material, which is the feature in distal myopathies. Now, these are the adult onset forms. The distal myopathies, you see the presence of these rimmed vacuoles. So the diagnosis of muscular dystrophies, there are two ways of diagnosing muscular dystrophy. That you need to pick up these protein defects in them, and that is, one is by the immunohistochemical staining, the other one is by immunoblots. Of course, you have genetic analysis for dystrophinopathies and the other forms of muscular dystrophy. So what I will be showing you are the couple of slides stained for immunohistochemistry. Now all these proteins that we are talking about, they are localized to the membrane of the muscle, and they are called as the membrane proteins. They are the dystrophin and the dystrophin associated glycoproteins. So all these proteins, no matter what antibody you use, you have the staining pattern along the membrane. Now this is for dystrophin 1, 2, and 3. These are for the 3 different domains of dystrophin. And if you suspect a case of dystrophinopathy, it is absolutely essential that you do the staining for all the 3 domains. Then you have myrosin, which is an extracellular protein which is defect in certain conditions like the congenital muscular dystrophy, a form of congenital muscular dystrophy. You have myrosin which is deficient. Alpha, beta, gamma, delta sarcoglycans, again, are the childhood onset autosomal recessive muscular dystrophy. Now, based on the absence of these proteins, we can subclassify them. Then there is another protein called dysferlin, which is again a membrane protein, and we have found that amongst the adult muscle disorders, dystrophinopathy is the most common one. Now, this is how you diagnose cases. Now, this is a case from Duchenne muscular dystrophy. You have the muscle which shows variation in the fiber size. This is a hematoxylin stained. Then you have these fibers, which are the necrotic fibers which have undergone myophagocytosis. And these basophilic fibers are the ones which are the regenerating fibers. And if you do a dystrophin staining, you see that there's absence of dystrophin for all the 3 domains, and you're very confident to call it as a Duchenne muscular dystrophy when you have a picture like this. But then please remember that it is not always true. You have one terminal being absent, the other being preserved, or 2 of them being absent and one terminal being preserved. So we have seen a spectrum of all these staining pattern. And you have the other sarcoglycans. You have to do the other sarcoglycans if you have to arrive at the diagnosis of Duchenne muscular dystrophy. You have to do dystrophin. You also have to do the panel of sarcoglycans along with myrosin. Now this we always add to the panel because it will tell you the integrity of the membrane. Since this is present outside in the extracellular protein, by doing this you know that the integrity, if it is positively labeled like this, you know the integrity of the membrane is maintained. Now, to give you an example of the other form of muscular dystrophy, which is the sarcoglycanopathy, this again clinically and histologically mimics Duchenne muscular dystrophy, particularly the gamma sarcoglycanopathy and, of course, the delta sarcoglycanopathy. Here you see that there is, of course, the changes that you see here on hematoxylin. The dystrophin protein is well preserved, whereas it is only the alpha sarcoglycan that is absent in them. The others are reduced, so you can offer the diagnosis based on this. So this is a case of sarcoglycanopathy, which mimic, I told you, clinically and histologically Duchenne muscular dystrophy. Now, coming to the next group of muscle disorders, you have the congenital myopathies, where the patients can present like floppy babies, and they are the ones with nuclear abnormalities in the fiber variation. Then you have sarcomere abnormal. There are various forms, and to identify or diagnose these, you definitely require enzyme histochemistry, and in the absence of enzyme histochemistry, electron microscopy plays a very important role. Just to give you a few examples of these conditions, this is from a case of central nuclear myopathy, and as the name indicates, you have the centrally placed nucleus in almost all the muscle fibers. The normal muscle fiber has a peripherally placed nucleus, whereas in this particular condition, you have all the muscle fibers with centrally placed nucleus. This is from a case of core disease. Again, you require enzyme stain for diagnosing. This shows the absence of enzyme activity, which is the core region in central core disease. This, of course, you're familiar. I have shown you this earlier. The mammalian rods, which on electron microscopy will tell you what exactly this is. And these rods are nothing but they are excess of the Z-band material. Then you have the other metabolic disorders, which again present like floppy babies, and the most common one amongst them is the glycogen storage disorder. You also have the lipid storage disorder, which can present like a floppy baby. Here again, you require enzyme histochemistry for diagnosis, where you require fresh tissue, and of course, electron microscopy can give you the diagnosis in the absence of enzyme histochemistry. This is from a case of mitochondrial disorder. This is how the hematoxylin eosin stain appears. These are the classical ragged red fibers on the modified Gomery strichrome, the ragged blue fibers, and this is another very important stain, the cytochrome C oxidase. We do a combination of cytochrome C oxidase and STH, which will give you the cytochrome C oxidase deficient fibers, which will tell you again or points towards the mitochondrial disorders. This is the classical example of the glycogen storage disorder, where the muscle fibers present like a vacuolar myopathy. There is marked vacuolation of the muscle fiber. The relatively normal ones are these, whereas all these are the ones which are vacuolated. And these vacuoles are per iris skiff pass positive, suggesting that all the glycogens, the vacuoles are stored with glycogen material. And one of the markers that we use also to confirm the diagnosis is acid phosphatase staining, because some of these are the lysosomal vacuoles. You get positivity within the vacuoles when you do this particular staining. And this is an example for the lipid storage disorder, where the vacuoles, again, the vacuoles are very fine here as compared to the previous one. And these vacuoles are loaded with this lipid material, which can be identified by oil red O. Now, the other most important tool for diagnosing muscle diseases is the electron microscopy. And electron microscopy is used as an adjunct to enzyme histochemistry as a confirmatory tool in mitochondrial disorders and all the storage disorders and in congenital myopathy. It is a diagnostic tool for other metabolic disorders like the neuronal ceroid lipofuscinosis. Now, this is the normal muscle. You have 3 muscle fibers at electron microscopy. The high magnification showing you the actin and the myosin filaments, and the longitudinal section clearly depicting the alternate light and the dark bands that you see. The name skeletal muscle also gets is a striated muscle, is because of the presence of these striations. Now, here you have the mitochondrial disorder. All these that you see here are the abnormal mitochondria. The mitochondria are abnormal in the cristae pattern. I don't know why this panel is not lighting up. So these are all the mitochondria which show abnormality. Some of them are very large, some of them are concentric lamellated, some of them are vacuolated, and these show abnormality in the cristae pattern. While others can show inclusions within the mitochondria, and these are the inclusions that you see in the mitochondria, and they're called as the parking lot type of inclusion. They're type 1 and the type 2, which again you see in the mitochondrial disorders. Now, one condition, metabolic disorder, that we can diagnose using electron microscopy when a muscle biopsy is done is the neuronal ceroid lipofuscinosis. These are the characteristic curvilinear inclusions. Now, based on this, we offer the diagnosis. The choice of biopsy in these conditions is actually the skin biopsy, where you can demonstrate these inclusions. But if a muscle biopsy is sent, you get the identical inclusions even in the muscle tissue. So these are the inclusions that you see in the muscle, and you can diagnose these conditions by electron microscopy. Now, diagnosis is possible on paraffin section, just to call it as a muscular dystrophy, just to call it as a neurogenic disorder. And of course, in the inflammatory disorders, you don't require enzyme histochemistry. And one condition, the centronuclear myopathy, you can diagnose by paraffin sections, whereas you will miss out on the diagnosis of all these conditions if you fix the tissue in formaldehyde. Now, I'll just brief you about our institute, because we do get a lot of muscle biopsies from all over the country as well as from the neighboring countries. We get from Bangladesh, Sri Lanka, and Oman, and look at the number of states that send the biopsy to us. NIMHANS is a tertiary referral center for neuromuscular disorders, and these are the statistics of our institute. We get a lot of referral cases, and the referral cases outshoot the biopsies that we do at NIMHANS. And the split up of the cases that we see, the most common ones that we come across are the muscular dystrophies, followed by the neurogenic disorders, and the others, the congenital myopathies, are just 2% of the cases. And of course, I'll skip all these. I just want to draw your attention to this particular table where muscular dystrophies are really large in number. We have a large series of muscular dystrophies, and these are all the ones which have been diagnosed using the immunohistochemical staining. So we have Duchenne, the Beckers, the manifesting carriers, all the sarcoglycans, dysphalinopathies, and calpainopathies. And recently, this is through a project mode, we have identified additional limb-girdle muscular dystrophy based on the Western blot analysis. So we have done characterization of limb-girdle muscular dystrophy using immunohistochemistry as well as Western blot. And we found that a large number of cases of calpainopathies. We have found teletoninopathies also being present in our population, sarcoglycanopathies, of course, and dysphalinopathies, I told you. And the other most important one is the LGMD2I. We have had a lot. These are called as the FKRP-related disorders. We have a large number of this. And remember, I would like to tell you at this point that all of these patients with FKRP disorder, that is alpha-dystroglycan deficiency disorders, they mimic clinically Duchenne muscular dystrophy, the younger onset with classical cardiac involvement, calf muscle hypertrophy, as well as the macroglossia. And the Becker's type of muscular dystrophy, like the Becker's phenotype, is also seen. So you have the early onset and the late onset mimicking the dystrophinopathies. Now, these are the various congenital myopathies. I'll skip and then go to the infantile and childhood one. This is only till 2008. I don't have an update. So we have come across all these conditions, and it was possible only by muscle biopsy. Now, take-home message for all the students who are here. Muscle biopsy to be interpreted with clinical history. Now, this is absolutely essential. You just can't send a muscle biopsy and ask us to report. We should have good clinical history along with the muscle biopsy. It's a clinico-pathological correlation. Then muscle fixed in formaldehyde will have very little information, so please do not fix the tissue. Send it fresh, and how you have to send, I have already told you all. Then fresh muscle biopsy, fresh muscle is of course important for all these conditions. Electron microscopy has a limited use only for congenital myopathies when you don't have enzyme histochemistry, and of course the metabolic disorders. Genetic analysis is now available for dystrophinopathies, myotonic disorders, and spinal muscular atrophies. Only when you fail genetic mutations in them, then can you send a muscle biopsy. The other forms of dystrophies, you absolutely require fresh muscle. And the last message that I would like to tell you is these muscle biopsies are absolutely essential, and enzyme stains and immunostains will allow you to select for genetic studies. Now, if you send the genetic sample, which gene are you going to ask them to look for, unless you don't narrow it down at the using the pathological techniques. Thank you. This is our institute, this is the administrative block, and this is the hospital, which is called the Neurocenter.
Is to get the message across that muscle biopsy is has to be sent in a specific manner, because otherwise many times I'm sure we receive biopsies and then the pathologists are not able to help us with the much because there are no clinical details or the muscle has been sent the wrong way around. Without much ado, because we have a whole load of clinical cases that we want to discuss, I just thought just to touch briefly on the clinical recognition of various, some of the common muscle disorders, which I'm sure most of you are familiar with, but I just thought it'll be good to highlight some of them because there are so many. And the common ones being the anterior horn cell disorders, the typical is the type 1s, which present early. I'm sure most of you are familiar with it. I won't go through the details. When we did look at the SMAs a few years ago, we found that about a good proportion of them, although we don't seem to achieve the numbers that internationally they quote, we had only, out of the 63, we had only 52 who had deletions of the telomere corpus. Interestingly, the NAIP ones, so the ones who had deletions in the neuronal apoptosis inhibitory proteins, appeared to be much more severe as compared to the ones who did not have them, but that numbers are so small that there is nothing much we can comment on it at this moment of time. We do have a number of cases who children who are not able to stand or walk, have progressive scoliosis with spinal muscular atrophy type 2, and the milder ones of the spectrum of spinal muscular atrophy, where most of them are walking, but they're always wide base gait, ataxia with preponderance of weakness in the proximal muscles. They have a good chance of becoming wheelchair bound by early adulthood. The peripheral nerve disorders are very many, and again, the more you read about Charcot-Marie-Tooth disease and the more you understand the genetics of it, the more confused you become, because it seems to be so vast now. There's almost a gene cropping up every other day that at the end of the day you don't know what but to make it simple, the classic pes cavus deformities and the peripheral involvement are the suggestions, and you examine the mother or the parents because they are also invariably involved, or they're unaware of what exactly is going on. Professor Dubowitz actually mentioned that in one of the Lancet papers about the cows behind the number of genes being evaluated for Charcot-Marie-Tooth disease. The muscular dystrophies are very many. I won't touch upon Duchenne too much because we've had a lot of talks about Duchenne muscular dystrophy. Just wanted to highlight that in our own study, good proportion of them had no deletion, which was in keeping with probably what's seen in the rest of the world. Just been part of our international effort. We've actually published a paper recently in neurology. There are more coming. This is possible only through the UC Davis, Dr. Craig McDonald and his colleagues from California. We've been part of their natural history studies, because interestingly, although we know about Duchenne so much, there is very little data that is published in the literature about what really happens to these children, which proportion, how many of them get, let's say, get into respiratory involvement, at what ages do they happen, what about the bone densitometry? I mean, there was a lot of discussion about bone densitometry yesterday, and again, these are not clear, and which the genetic, I mean, is there a phenotype-genotype correlation at all? So we did, we've been following up with these kids over the last 9 years or so, and we hope to continue this with more grants coming at least for the next 20 years, and hopefully we will get more idea about what actual Duchenne muscular dystrophy is all about, and that will help us when we get into the treatment modalities, because many times when we get into treatment, we are not aware actually what really happens to the natural history of the disease, and is it part of the static phase of these illness. When we did look at a study bias looking at the in-frame versus out-of-frame, clearly the out-of-frame children who had out-of-frame deletions did not fare as well as the in-frame, and this is well known, nothing new about it, but this is part of our own efforts to look at Duchenne. Becker muscular dystrophy is pretty common in our country, and again, it's important that we identify these people early. As Dr. Gaitri already alluded to, sarcoglycanopathies are not uncommon in our country again, and many of the sarcoglycan children present very similar to Duchenne. They can occur in boys as well as girls. The prognosis is variable. There's not much of cardiac involvement, but the dystrophin is present, and sarcoglycans are invariably absent, like in this child. And alpha sarcoglycanopathy seems to be much more common as compared to the rest of the sarcoglycanopathies. And this young girl, wouldn't forget, because they came from the east of the country with a diagnosis of leukodystrophy, just because she was not able to walk at the age of 2.5 years, and somebody had done a scan and found white matter changes in her brain. And that's not uncommon, and nothing wrong with the doctor, just that he was not aware of other conditions. And then the clinical clue was the fact that she was having significant proximal muscle weakness, which then led to the diagnosis of medicine-negative congenital muscular dystrophy. The medicine is completely absent. So these children do have these white matter changes, and interestingly, we've got a good bunch of them. All of them, the white matter changes do not seem to progress. Unlike your leukodystrophies, they seem to persist, although we haven't been doing yearly scans on all these kids. It's just that they're in the ones where we have done scans a few years down the line, we find that these white matter changes do not seem to change much over a period of time. And the good thing is they do well. I mean, this was the first slide was in 1999, and then 2005. She's still coming to me, and she's doing very well indeed. So over the last 13, 14 years, she's only kept improving, and she's attending normal school or regular school. So they do well as compared to the other children, although the white matter changes do remain. Facioscapulohumeral dystrophies are not uncommon, and they do cause as much problem as your other forms of muscular dystrophies for the child. And this is another interesting with the arthrogryposis, hypotonia, high CPKs has, I think, Professor Matthews yesterday did show some slides similar to this with the not much brain, poor gyri and sulcation in the brain. And as Dr. Gaitri said, FKRP mutations are important. I mean, the fucotin-related protein, we don't have the facilities as yet, but I'm sure if we do look for them, we would find more cases of Fukuyama type of muscular dystrophies in our country. Another not so uncommon, I mean, we have about half a dozen children with this condition, they present with difficulty in opening the mouth, pursed lips, myopathic facies, and a pretty muscular build in these children, and difficulty in climbing stairs. We did publish a series a few years ago in the Turkish Journal of Neurology. They have this myotonic discharges and very thin osteopenia, and most of them, and Schwartz-Jampel syndrome is interesting because these children again appear to be quite static. She's actually attending a normal school and doing better. What's interesting is, the usual phenytoins and the carbamazepines that we tend to use in myotonic dystrophies do not appear to make a significant amount of difference to these children as compared to, I think in spite or even with our treatment, she's still doing well. Thank you very much. And that's exactly what the parents said. She said the parents came and told me saying that, Doc, thank you very much. We did try your medicines, but it doesn't seem to make a difference. But they still come at least once in 6 months and show us once in a while. As far as the myopathies are concerned, we see the whole spectrum again, classically with the valgus deformity of the feet, normal CPKs and the myopathic patterns on the EMG. We have a good number of children who have BiPAP ventilation at home. I mean, this young lady, this was taken in 2005. She's actually in college now. All she does is uses the BiPAP at night to sleep comfortably, because otherwise she finds it difficult to lie down comfortably. When she came initially, because she lives well beyond Kadalur, somebody was saying, doctor, this won't work out, but thankfully enough, they are very good. The parents regularly, and the servicing is also very good of the machine, and they are, although they are not highly educated and not very wealthy, they're doing brilliantly with the BiPAP machine. So I think we should consider home ventilation, and these machines are becoming cheaper, and many of them have been provided by us free of cost from our MDA, and we will support any family who really cannot afford to buy the machine. We will be happy to support them to get the machine and have a comfort, because otherwise sleep becomes a problem. Early morning headache and vomiting becomes a problem in many of these children. This is another child with the vacuolated myopathies. And again, Pompe's is important to diagnose with the floppy child with the respiratory difficulties, and you can see the tracheostomy. Important to diagnose because there is a cure available. And again, good thing about India is, although enzyme replacement is expensive, we do have support from the WHO for these children. And anybody who requires, they do have to pay up initially a significant amount of money, but many of, at least a few of our patients are on enzyme replacement therapy. It's too early for me to comment on how, it's too early for me to say they are doing brilliantly, because I haven't seen too much of major clinical improvement, but they haven't deteriorated and they're doing very well. So I guess it's early days, certainly from my experience, because it's over the last 2-3 years that we've been doing this. But the Pompe's, since there is a cure, I think it is important that we diagnose it early, counsel the family, and get these kids involved. And certainly the earlier you get them involved into the enzyme replacement therapy, the better it'll be in the long term. Sphingomyelinase deficiency, although does not come under neuromuscular disorders per se, I just thought it's important to highlight that there are other disorders which present with a floppy infant, and many of them, I know how many of you have seen cherry red spots. They're not that difficult to visualize, and they're important to pick up because this gives us the diagnostic clue and to know where we go for. And that is why clinical medicine is very important, because at the end of the day, the diagnosis lies with what we are able to identify clinically, much more than from our diagnostic tests. We do the other whole group of disorders that we see is like this young lady who was 18 years at the time. I saw her in 2004. She had leg cramps while walking, stressed. At 7 years, had hand tremor during piano classes. Then she started deteriorating by about 10, and where she was dropping things, worsening coordination, difficulty walking and climbing stairs. And what's dramatic about her is this MRI that she had in Singapore in 1999, and what we saw in 2004, progressive shrinkage in the brain, and of course the few EEG changes suggesting that she was actually getting these jerks, what appeared like myoclonic jerks. Her ERG showed a pretty much a flat pattern, suggesting that there was involvement of the eyes, the brain, as well as obviously the weakness was progressing. The SDH aggregation, the NADHDR aggregation, confirmed that she did have a mitochondrial disorder, and many of them present with features of muscle weakness, because that's what is obvious to the family, rather than actually the rest of the subtle findings. Myasthenia, again, is not uncommon. And what's interesting is congenital myasthenic syndromes are pretty much common. It's just unfortunate we don't have facilities for looking at it in a deeper, and I don't know whether Dr. Gaitri can help us with exploring the idea of looking at the neuromuscular junction in a little more detail, because we do have a good number of cases of children with congenital myasthenic syndromes presenting with very early onset ptosis and poor eye movement as well. And some of them do respond better with neostigmine, or we did look at the genes of these children. This was part of our CMS patients. The 1267 del-G mutation was strongly positive in our population. Interestingly, this was quite different from the CMS mutations they had in Europe. And Hans, my collaborator, was pretty much surprised when we did look at the whole thing. And he was saying, Vish, this is very interesting, because from where we started, although we started with a straightforward study, we realized that the gypsy population had migrated from India many years ago. So it led to some founder effect, and a completely different story from there. But this is something that we need to look at in more detail. There are other neuromuscular disorders, particularly dermatomyositis and polymyositis, not uncommon in our country. And again, something that if picked up early and treated appropriately, they do much better. And therefore, one needs to look for these clinical clues, Gorton's papules. If otherwise, we could miss them and we end up not diagnosing them. I know, again, hypothyroidism is not a neuromuscular disorder, but I just wanted to highlight that we still seem to see it because we don't have the neonatal screening as much as we would like it to happen, and therefore we do now and again have floppy infants presenting with in our OPDs. So do consider that as a possibility, something eminently treatable, and the kids do well. And this young man, when he came to us, had, with severe respiratory difficulties, had a huge PCO2 of 89.7. bicarbonate of 37.4, so suggesting that he's had chronic lung issues, although interestingly, he did not decompensate until the time he presented to us, which was interesting because many of these kids are not that good, and he has got these straight back with the wasting of the muscles, both at the back, scapular, humeral, and peroneal groups of muscles. I haven't shown you the peroneal group, but he had wasting all over. And this whole alert-looking boy had features to suggest that he had severe restrictive lung disease as well. So with that combination of the scapulohumeral peroneal wasting and the severe restrictive lung disease, this was the more likely diagnosis of Emery-Dreifuss muscular dystrophy, usually presents during adolescence, and they do have contractures, which this boy had. So contractures of the ankles and the elbows, the scapulohumeroperoneal wasting, severe restrictive lung disease, and pretty much a normal intellect would did suggest that he had Emery-Dreifuss muscular dystrophy.